All right, so welcome to Krok 1 2015 booklet. Today is the fourth tutorial. All right, so let us begin. So a doctor asks a patient to make a deep exhalation after a normal inhalation. So what it means is that deep exhalation, breathe out, deep one after a normal inhalation. The question is, what muscle contracts during such exhalation? What muscle contracts during such exhalation? And I've not taught you guys this, but then you must understand that the primary inspiratory muscle, I think we've done it. The primary inspiratory muscles are the diaphragm and the external intercostal muscles. That is inspiration. You use your diaphragm and you use the external intercostal muscles. So these are the major, muscles that are involved in inspiration or in inhalation. Now, muscles that help in forceful expiration include internal intercostal muscles, subcostal, and what we call abdominal muscles. Abdominal muscles. These are the muscles that are involved in forceful expiration or exhalation. Exhalation. So you need to understand these things. So looking at our option over here, of course, your likely answer should be what? The abdominal muscles. The abdominal muscles. However, in normal inspiration, you use your external intercostal muscles and you use your diaphragm. We also have what we call the accessory inspiratory muscles. Accessory inspiratory muscles. These include, the ribs and the sternum and things like that. Sorry, these include the muscles of the sternocleidomastoid. Sternocleidomastoid muscles. These are the accessory inspiratory muscles. Then you can talk about the scalenum anterior, scalenum medial, scalenum posterior, pectoralis major and minor. All of these things are involved in what we call accessory inspiratory muscles. You can also talk about accessory expiratory muscles, which include the abdominal muscles, the rectus abdominis, the external oblique, and so on and so forth. These are all things that are involved in inhalation and exhalation. So my thing is this: do your possible best to know these muscles by heart. But of course, for the benefit of our discussion, we are looking for what? Forceful exhalation. And that you are thinking of what? The abdominal muscle. So your answer is C. All right. Now, a 4-year-old child with hereditary renal lesion has signs of rickets. And you and I know that ricket has to do with what? Of course, with calcium. With calcium. We talked about this the last time. So if you aren't here or if you forget about it, please, if you have forgotten about it, do well to attend to those videos. Okay. Now we're having vitamin D. However, they are saying about vitamin D concentration is normal. What is the cause of rickets in this development? Again, we've We've established that ricket has to do with what? Insufficiency of vitamin what? D. However, the active form of vitamin D is what? Is calcitriol. Calcitriol. And these are dependent on what we call 1-alpha hydroxylase. 1-alpha hydroxylase, which is produced in the kidney. So if you have a kidney lesion or a kidney problem, what it means is that this alpha 1 or 1-alpha hydroxylase will be impaired. And if it is impaired, regardless of the fact that vitamin D concentration is normal, this vitamin D will not be activated for it to carry out its function, isn't it? So over here, we are having impaired synthesis of calcitriol, which is the active form of vitamin D, the active form of vitamin D. So your answer here is A. A cat with decelerate rigidity, the muscle tone is to be decreased. This can be achieved by what? This can be achieved by what? I don't know if I've said it here, but usually when we are dealing with the muscle tone, when you're dealing with the muscle tone, what basically comes to our mind is usually what? The vestibular system. The vestibular what? System. These are the things that comes to mind. The vestibular system. It deals with muscle tone. So here's a case we're having what? A decelerate rigidity of this muscle tone to be decreased. So what are we thinking about? Of course, we are looking at for what? The vestibular what? Nerve or the vestibular what? Nuclei. These could be destroyed. And when these things are destroyed, of course, we are going to have what? This muscle tone to be what? To be decreased, And usually, when we talk about these vestibular nuclei and stuff like that, we are basically dealing with the somewhere below the red nucleus. And inside the vestibular nerve, we have 4 nuclei. I don't want to go into details for that, but we have 4 what? Nuclei. We have the superior, the inferior, the lateral, and then what? The medial. The lateral is also known as the diates, or the diates, however you want to pronounce it. All right. So definitely, like I said, I don't want to go into details of all of these things because it might end up confusing you. But basically, we are looking at for what? Loss of muscle tone. And loss of muscle tone, we are dealing with what? The destruction of the vestibular nuclei. So here, your answer should be B, destruction of the vestibular nuclei. Again, these deals with muscle tone. An autopsy of a 5-year-old child revealed in the area of vermis of the cerebellum, a soft grayish pink node 2 centimeters in diameter with a blurred margins and areas of hemorrhages. Histologically, this tumor consisted of atypical monomorphous small round cells with large polymorphous nuclei. What tumor are they looking at for? So basically, we are looking for what? For a cerebellar tumor. And of course, we are looking for what? A medulloblastoma. This is a cancerous tumor. It is also called cerebellar primitive neuroectodermal tumor. I repeat, cerebellar primitive neuroectodermal tumor. I hope you guys are writing some of these things because the more you write, the more you listen, it sticks in the head. And the more you practice, it sticks in the head. And talking about practice, do well to have access to our app. Now it's available on the Play Store. So do well to have the app to practice instead of going to all these other sites where it has no explanation. On the site, you can get all these explanations over there. We can help you to remember all of these things, okay? This is different from the video anyways. All right. So again, we are talking about what? The cerebellar primitive neuroectodermal tumor, because the question is telling us that we are having a tumor inside the cerebellum. And again, another name is what? The medulloblastoma. So basically, that is what we are looking out for. And this is usually located at the base of the skull. Also called the posterior fossa. And this is where we can have the vermis of the cerebellum. So again, this is an anatomical finding. So it would be best if you can get, the anatomy, the atlas, and look at for these terminologies, or the vermis You can realize that it's found at the posterior section or the posterior fossa. So the answer here is E. Surface with an intact toad on it was inclined to the right. Tone of the extensor muscles became refractory higher due to the activation of the following. Guys, I made mention over here in our just previous slide. What controls muscle tone? Who can tell me? Muscle tone.
Vestibular system.
The vestibular system. So even without knowing your answer, you know the muscle tone deals with the vestibular system. And over here, they are saying that the tone of the extensor muscle has become refractory higher due to the activation of the following receptors. So even without knowing, you should know that you are going to be dealing with with the vestibular system. You see how interesting medicine is. Exactly. So you're going to deal with the vestibular system. But then again, over here, don't forget, we have what we call the semicircular canals, and then we have the utricles and the sacos. Okay. Now, when we talk about the how do I even put itself? The sacos and the utricles, we are dealing with linear motions. I repeat, we are dealing with linear motions. And when we start talking about the semicircular canals, we are dealing with with moving around. Now, let me give you an example. Have you realized that when you're in a car moving, the car is moving in a top speed, and all of a sudden it stops? Do you realize that when it stops, involuntarily you continue to move forward before you can now come back? Can anyone testify to that? Anyone?
Yes.
Indirectly, unconsciously, you just continue to move, even though the car has stopped, but the body will still continue to move. That is what the utricles and the sacos working for you. And that's beautiful, isn't it? Now, at the same time, when you sit on the merry-go-round, that thing like a circle, those of you who like to enjoy games, you realize that when you sit there and it begins to move, you are enjoying. As soon as they bring you out of the merry-go-round and they leave you, you continue to spin. That is because the semicircular canals are still moving. So you continue to spin until the body says, that guy, you are no longer spinning. So calm down. That is what it happens. So if you understand these things, you will enjoy medicine. So over here, we are dealing with a linear motion. Linear motion. So over here, your answer is what? Of course, the vestibular receptors of the utricles and the sacos. So your answer here is E. If it was on merry-go-round, your answer is what? Is B. But this is inclined to the right. To the right. That means it's more or less linear. Linear, including gravitation. So that you are and sometimes when you're in the lift, the same thing happens. It's also a linear motion, though it is moving upwards, but it's a linear motion. In a car, it's moving horizontal, but it is still in a linear motion. So please take note of some of these things. So here, we're looking at E as our answer. Now, a patient with high titer nuclear antibodies died from progressing renal impairment. Okay. Autopsy revealed mesenteroproliferative glomerulonephritis and abacterial polypus endocarditis. Periarterial tubular sclerosis was detected in the spleen, and productive proliferative vasculitis in the skin. What is your diagnosis? So again, we are saying that we are having an anti-nuclear antibodies, which is also affecting the kidney, as well. Have you guys heard of lupus lupus nephritis before? Yes, this is typical for lupus nephritis. Lupus nephritis. And of course, the general disease is the systemic lupus erythematosus. Systemic lupus erythematosus. And this is an autoimmune disease. Autoimmune disease, which the body mistakenly attacks healthy cells. It mistakenly attacks healthy cells. And usually this comes with painful and swelling of the joints, fever, chest pains, hair loss, mouth ulcers, lymph nodes enlargement, feeling tired, etc., etc. But one of the key features that you need to take note why we are saying this is lupus erythematosus is the presence of anti-nuclear antibody. So please take note, this anti-nuclear antibody test, we use it to check for systemic lupus erythematosus. I repeat, ANA. ANA means anti-nuclear antibiotics. ANA. So ANA test is for what? Systemic lupus erythematosus. Systemic lupus erythematosus. Another test that we also use is the anti-extractable nuclear antigen. Anti-extractable nuclear antigen. So in your question, in case they don't bring this anti-nuclear antibody, but they do bring anti-extractable nuclear antigen. Don't say Dr. BAHA did not say this into us. It's the same lupus erythematosus. So here, your answer is A. When studying the signs of pulmonary ventilation, reduction of forced expiratory volume has been detected. Forced expiratory volume has been detected. What is the likely cause of this phenomenon? So, ladies and gentlemen, the question goes, I'm going to ask you guys. Now, you're having a case whereby expiring or breathing out is difficult. Breathing out is difficult, or the air is reduced. Air is reduced. What do you think could be the reason for that? Who can tell me? Breathing out. Obstruction. Thank you. Something is definitely obstructing it. Example are people who have asthma. So people with asthma, their forced expiratory volume is decreased. And that's because we are having what? An obstruction in the bronchus. Obstruction in the bronchus. So over here, we are looking at what? Obstruction. So therefore, your answer is what? Obstructive pulmonary disease. Obstructive pulmonary disease. This is just beautiful. All right. A specimen of a parenchyma organ shows a poorly delineated hexagonal lobes surrounding a central vein, and the interlobular connective tissue contains embedded triads. That's an artery, a vein, and an excretory duct. What organ is this typical of? This is typical for liver. This is typical for liver. And I don't know how you want me to explain it to you, but this is liver. So in liver, in the center, we are having what we call the central vein. The central vein. The central vein. And that is very, very specific for what? For liver. And usually, people can describe liver or the structure of a liver in three ways. In three ways. We have the classic lobo, we have the portal lobo, and we have the liver what? Acinus. The liver what? Acinus. So because these are the classic ways of what? Or these are the three ways of describing the structure of a liver. Classic lobo, portal lobo, and the liver what? Acinus. The liver acinus. So basically, this is just to add up to whatever that we already what know. And when they talk about the triad, they're talking about what? The portal triad. And you know the portal triad, we have the artery, or the hepatic artery. We have the portal vein, and we have the bowel duct. So that's what it is describing over here. So this one is the hepatic artery, the portal vein. Then we have the bowel duct, which is an excretory duct. So please don't get confused with all of these things. Then inside it we have the hepatic venule or the central vein. All right. So here your answer is A. Your answer is A. A patient had a trauma that caused dysfunction of motor centers, regulating activity of head muscles. In what part of the cerebral cortex can the respective center normally be located? In what part of the cerebral cortex? So over here, we are talking about there's a trauma caused by dysfunction of the motor center. So over here, your clue here is what? Dysfunction of the motor center. So you need to ask yourself, which part of the brain control the motor centers? And of course, you are having what we call the precentral gyrus or gyrus. The precentral gyrus. This is also known as the motor strip or the motor center. Again, so we call it the primary motor cortex. The primary motor cortex. So please take note of some of these things. Now, if you're talking about proprioception and the sense of touch and things like that, you are definitely looking at for the post central gyrus. Post central gyrus. But even under precentral gyrus, we have different parts. We have different parts. So the lower part of the body are represented by the upper or the superior surface. Again, the lower part of the body, we are having the upper or the superior surface. And in the upper part of the body, which is the head muscles of the body, are represented with the lower or the inferior surface. Lower or inferior surface. So over here, since we are talking about the head muscles, that means we are referring to what? The lower or the inferior surface. Lower or the inferior surface. And that's why over here, your answer will be what? Will be D. But if they has talked about what? The lower extremities or, the lower parts of the body, then you are thinking of what? The upper or the superior surface of the precentral gyrus. Precentral gyrus. All right. Sometimes to the superior, they can call it the lateral. The lateral. Sometimes. All right. So that's just by the way. So your answer is what is D. Before that, an assignment, go and look for the function of supramarginal gyrus. The function of supramarginal gyrus or gyrus. Please look for it. All right. Now, during intravenous saline transfusion, a patient's condition deteriorated drastically. So transfusion, and there was deterioration. And the patient died from asphyxiation. That's hypoxia. Insufficiency of what? Of oxygen. Autopsy revealed acute venous congestion of internal organs with a sharp right heart dilatation. When the right ventricle was punctured underwater, the bubbles escaped. What pathological process occurred in the patient? Now, they are saying, now your clue is here, guys. This is your clue. When the right ventricle was punctured underwater, bubbles are air. Bubbles are gas. They are saying bubbles escaped. bubbles escaped. So whatever that is causing the asphyxiation or the dyspnea or the hypoxia is because there is gas embolism, or there's what we call air embolism. Air embolism. So over here, we are looking for what? Air embolism. And also, this is also what? Of course, when you see bubbles of air or gas in the circulatory what system, you are thinking about what? Of air embolism. And that's what over here we are going with what? Air embolism. So the answer here is what? Is C. Air embolism. Air embolism. All right. And I don't know why they have to bring air at the same time, gaseous embolism at the same time. But your answer is the most appropriate one is air. Now, diseases of the respiratory system and the circulatory system impair the transport of oxygen. Disease of the respiratory system and circulatory system impair the transport of oxygen. That is causing what? Hypoxia. Under these conditions, the energy metabolism is carried out by anaerobic glycolysis. Guys, I've said over here countless number of times, anytime you are having anaerobic glycolysis, what are you going to produce, or what is the end product? Who can tell me?
Lactic.
Lactic acid. You guys are too good. So your answer is what? Is D. This I don't need to worry myself. Examination of a 6-month-old child revealed a delay in the closure of the occipital fontanelle. When should it normally close? When should it normally close? So write this down. Occipital fontanelle usually closes by the time of 2 to 3 months old. I repeat, occipital fontanelle should be closed 2 to 3 months time. Then anterior fontanelle should be closed by 7 to 18 months time. 7 to 18 months time is for what? Anterior fontanelle. Then occipital fontanelle within 3 months. Now I'm saying this because maybe Krok can say the anterior fontanelle. Then you will say BAHA didn't tell me. So over here, since we are dealing with occipital fontanelle, your answer is what? 3 months. Or before 3 months, or at 3 months. Sex chromosomes of a woman. Look at it. Sex chromosome of a woman. So we are talking about a female. Didn't separate and move to the opposite poles of cell during gametogenesis, that is meiosis. The ovum was impregnated with a normal spermatozoon. So that means there should be an X chromosome, isn't it? Sorry, Y chromosome, isn't it? Because they said the ovum was, however, impregnated with a normal spermatozoon. Now, which chromosomal disease can be found in this child? Which chromosomal disease can be found in this child? Don't forget, they said the sex chromosome didn't separate. And we know that, assuming this is your cell, at the equator, which is the center, or during the, is it metaphase or anaphase phase, chromosomes begin to what? Or homogeneous chromosomes begin to what? Separate to the opposite what? Poles, isn't it? Exactly. To the opposite what? Poles. So by the centrals, isn't it? Charlie, my anatomy is coming. My microbiology is coming. Biology is coming. By the centrals, okay, they begin to separate it. Now, if they fail to separate, that is the sex chromosomes of a woman. And you know, woman deals with what? With X chromosomes. The woman deals with what? X chromosome. And they're saying that that one failed to separate. Good. So that will mean that we are going to have no bowel body, because you know that a woman is supposed to have what? XX.
X.
Yes. Now they say that this one failed to separate and then move to the other side to join. So we're having what? Now we're going to have what? XO. Now we're going to have what? XO. 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 We're going to have what? XO. So, and again, this is what? A woman. So in a woman, you can't have Y chromosome. You can't have Y chromosome present. This is a woman. So you can have what? A Y chromosome present in a woman. And so therefore, you are thinking of what? A karyotype of what? XO. And karyotype of XO simply means Turner syndrome. Turner syndrome. In Klinefelter syndrome, though it's not here, but in Klinefelter syndrome, we have XXY. XXY. But this is what? Turner syndrome. By now, you guys should know cat cry, Down syndrome, Patau, Edwards, and so on and so forth. If you can't remember it, please. I think I've explained some of these things in our biology basis. Do well to watch them. Some have to do with 21 chromosome, 15 chromosome, 18 chromosome, and then chromosome 5. All right. So please take note of them. So this is what? Turner syndrome. Turner syndrome. And again, in some of the videos, I've explained trisomy X syndrome, what a bowel body is, and those things, please. This is a revision, so I don't want to waste your time. A patient was prescribed with loratadine. Loratadine. What group of drug is loratadine? Who can tell me? Loratadine, what group of drug is it? Tell me. We did it in pharmacology. Histamine. So you are dealing with a antihistamine or histamine inhibitors. Good. So the thing that this person was prescribed with a histamine inhibitor to treat allergic cellitis. What is the mechanism of action? So again, even before going to your answers, if we told you, you already know the group of drug. Your pharmacology is solid. And when your pharmacology is solid, you already know this, what? Antihistamine, which is the same as blockage of H1 histamine receptors. Histamine receptors. So your answer is what? Is A. As easy as A, B. So this is a bonus question for you. All right. And again, do what to watch our pharmacology videos, guys. We talk a lot about these things. During introduction of a local anesthesia, a patient has gone into anaphylactic shock. Anaphylactic shock. What drug must be administered to the patient? So we have explained in people in anaphylactic shock, the drug of emergency that we use is called what? Who can tell me? Quick. We've talked about this. Epinephrine. Epinephrine. Guys, when I ask you a question, don't answer in a way of asking me a question. Why am I saying this? You should know your answer. You should know them. So it's as if you are guessing. No. Don't be guessing in my classes, or don't be guessing when I give you pre-Krok or when you're answering questions. Don't guess. Be sure of your answer. You guess when you don't know. But this you know. This you know. Great. So don't say epinephrine. No. Epinephrine. Case closed. So your answer is what? Is C. Case closed. Is C. All right. A patient has been diagnosed with influenza. His condition drastically worsened after taking in antipyretic. That is, of course, against fever. He is unconscious. AP is 80-50. His pulse is 140 per minute. Body temperature has dropped to 35.8. What complication has developed in this patient? What complication has developed in this patient? And of course, since he has lost consciousness, you are definitely thinking of what? Collapse. So the person has lost consciousness, collapse, and that is resulting from taking the antipyretic drug. And I'll tell you why there is loss of consciousness. Usually, what antipyretic drug do is that they block prostaglandin synthesis. And by blocking prostaglandin synthesis, they block what we call cyclooxygenase enzyme. By now, you guys should know what COX-1 and COX-2 is. Cyclooxygenase enzymes. And when they block these enzymes, what it happens is that thermoregulating centers will also be blocked. Thermoregulating centers will also be blocked. And when thermoregulating centers are also blocked, of course, which is the center for the increase in temperature, when that place is blocked, it means it's going to reduce what? The temperature, isn't it? Now, in case of toxicity or too much antipyretic drug, what it does is that it can result in coma. It can result in coma because it's affecting the central nervous system. The central nervous system. So if there had been a coma here, we could have easily going in for a coma. But of course, closer to coma would be what? Would be the collapse, because there's loss of what? Consciousness as a result of giving the antipyretic drug. Medicine is sweet. Your answer here is E. Someone saying, you're enjoying it, right? Medicine there is nice. Oh. The answer is E. You see, this is what differentiates a medical doctor from perhaps a nurse. You know, doctors know the mechanism of every drug that is given. And when you know the mechanism and understand the mechanism, you don't suffer. You don't suffer at all, because you know when to do this, when to do that, when to do this, when to do that. But nurses, they don't know. All they know is that the person having temperature, give para, or give salt more. Then they are just giving, but they don't know the mechanism of action. But you, as a doctor, you know how to do it. Sometimes people come to the ward with high blood pressure. This is just to add up to it. High blood pressure. And people who come with high blood pressure, you don't give them normal saline. If you give them normal saline, their blood pressure will rise again. But nurses don't know that. They'll continue to give normal saline. No, you give Renges lactic. Don't worry, let me not bring my practical skills here, because we're not doing practicals here. You guys are just doing Krok 1. Let's stick to Krok 1. All right. An alcoholic has alcoholic psychosis with evidence of psychomotor agitation. What neuroleptic drug? Guys, we talk about what? A neuroleptic drug. We have discussed a neuroleptic drug. So what neuroleptic drug are you going to look at for in this case? Of course, aminazine. So this is typical a neuroleptic what? Drug, and it also has antipsychotic action. It has antipsychotic action. It has extrapyramidal effect. It has antiemetic effect. It also has antimuscarinic effect. So usually we can give this aminazine for people with psychosis, people suffering from schizophrenia, people suffering from hallucination, people suffering from delusions, and so on and so forth. That is why over here we are giving what? We are going to give the person what? Aminazine. So as an assignment, what is the meaning of antiemetic? What is the meaning of course, antipsychotic, the name implies. So what is the meaning of antiemetic? It's an assignment. Some of these I might not follow up, but please do it. It's for your own good. If possible, put it on the Telegram page, okay, so that we know that you are learning. Okay, learn. That's why I love Esther. Esther will be putting questions and even be scaring us. But don't worry, we'll get there, Esther. We'll get there. So over here we have what? Aminazine. So please, let's cultivate that habit. And Esther number 2, you're also very good. You don't contribute. I will start finding you. Now, during blood transfusion, a patient has developed intravascular erythrocyte hemolysis. What kind of hypersensitivity does the patient have? We are having what? Intravascular erythrocyte hemolysis. Before we go into this, as a form of revision, if we talk about hemolysis, what type of jaundice would it lead to? Quick. Oh. Come again?
Type
I was
2.
like obstructive.
Unconjugated.
Unconjugated. Someone is saying obstructive. What are we saying? Guys, listen. This is intravascular erythrocyte breaking down of red blood cells. I told you this is very, very, very specific for prehepatic jaundice. And in prehepatic jaundice, just as one of you said, you will have a lot of unconjugated bilirubin. Thank you. But this is what? Prehepatic jaundice, not post-hepatic or obstructive. No. In obstructive, you are thinking of a problem with the cystic duct, a problem with the pancreas. If hepatic, you are thinking of a problem with the liver. With prehepatic, you are thinking of a problem before the cells, the red blood cells enters the liver. So please take note of these sort of things. But then again, let's come back to our question. The question here is what? Blood transfusion. That means it didn't even take time. During blood transfusion. So what type of hypersensitivity are you looking out for? Quick. What's your answer? What's your answer?
Type 2.
Type 2 hypersensitivity.
Type 2
what?
antibody dependent.
Good. Exactly. This is what? Type 2. This is type 2. And I've explained these things to you guys. Type 1, type 2, type 3, type 4. The diseases that you are likely to find. And in type 2, we are having acute hemolytic transfusion reaction. We are having autoimmune hemolytic anemias. We are having a good pasture syndrome, grave disease, myasthenia gravis. All of these things fall under type 2. Guys, I don't want to go into type 1, type 3, type 4. Guys, I don't have that time to go into all of these things. But please, why I'm saying this, because we have done them already. We have done, and I like that. I think Yima or something was the person who answered is even telling me the mechanism, antibody. That's wonderful. So that means the body's immune system is reacting. Charlie, medicine is sweet. The answer is what? Is A. The answer is what? Is A. All right. In type 1, you know the diseases. In type 3, you know them. In type 4, you know them. We've talked about them. So please watch the videos. In the course of an experiment, thalamocortical tracts of an animal were cut. What type of sensory perception remained intact? What sort of sensory perception remained intact? And over here, we are looking at for what? The olfactory, how do you call it? The olfactory senses or the olfactory nerve. This olfactory nerve, the pathway, now the rest of them, they pass through the thalamus. The rest of them, auditory, visual, nociceptors. And guys, let's just rewind. When we talk about auditory and visual, what orientative reflexes are we talking about? I mentioned it several times. Who can tell me? What orientative reflexes are we talking about? Oh, can you guys remember we talked about something superior, something inferior? Can you guys remember?
Quadrigeminal.
Oh Lord. Oh Lord. Can I just hug you, please? Please, I want to hug you. So we
Yes,
are
please.
talking good. So we are talking about what? The quadrigeminal bodies. That's why I said, if you are listening to me very well and you're making notes, trust me, you will enjoy medicine. And if you watch the video over and over again, you will enjoy it. So we are talking about the quadrigeminal bodies. And quadrigeminal bodies, we have the superior and then we have the what? The inferior. This I'll not ask you. Go and look for what is responsible for superior, what is responsible for inferior. We've talked about this like 10 million times. So if you've forgotten about it, please, please, and please again, revisit the videos. Even in 2015 booklet, we have talked about something like this. But that's just by the way. Now we're talking about what? The olfactory nerve. That one does not pass through the thalamus, and hence it will remain what? Intact. Now, briefly, let me just give you the pathway for the olfactory nerve. The pathway. So there's the pathway. So we have the olfactory receptor cells, which will give rise to the olfactory nerve. From the olfactory nerve, we have the olfactory bulb. From the olfactory bulb, we talk about the olfactory tract. From the olfactory tract, we talk about the olfactory stria. From the olfactory stria, we have the olfactory cortex. From the olfactory cortex, we have the output target of the olfactory cortex. So you see, with all of this, I made mention of nothing related to what? To the thalamus. And that is why this olfactory nerve will still remain what? Intact. If I'm too fast, please do it to rewind. It's a video, so do it to rewind. Rewind it. The answer is C. A 4-year-old child presents with a general weakness, sore throat, deglutitive problem. That means some sort of what? Digestion or swallowing problem. After his examination, a doctor suspected diphtheria and sent the material to a bacteriological lab. To determine the diphtheria causative agent, the material should be inoculated into the following diagnostic medium. Ladies and gentlemen, again, we've talked about this in, I think, microbiology. We talk about it in microbiology, and we said the media for diphtheria is tellurate alga, and Loeffler alga. Loeffler alga is spelled as Loeffler, alga. So please take note of it. So we're talking about the tellurate alga as our what? As our answer. If you go through the microbiology tutorials, I made mention of other things that you need to what? To look out for in terms of some diseases and the kind of test that you need to do. I've made mention of a lot of them. So please do well to visit those videos. I don't want to bore us with all those explanations and things. Otherwise, the video will be too lengthy. That's why I took my time to build the foundation with you guys. So that when I'm doing this thing, I won't suffer. When treating a patient with a chronic cardiac failure, a doctor detected bradycardia and deterioration of the patient's general state. Such condition is caused by cumulative effect of a drug. So they've already told you this is caused by a cumulative effect of a drug. What drug of these isolated, this listed below, has an accumulative action? Accumulative what? Action. Accumulative action. And guys, just a little bit of, how do you call it? Revision. I love revision a lot. Just a little bit of what? Revision. We've talked about acute heart failure. We have talked about chronic heart failure, isn't it? Acute heart failure. I've told you the drug of choice for acute heart failures. Don't worry, I won't go into details because I want you guys to go in with the videos. Otherwise, you will be lazy. So go in with the videos. I talked to you guys about acute heart failure, what drug you use under pharmacology. So please go and search for it. And in chronic heart failure, I told you about the drug to use. So which drug do we use for chronic? Who can tell me?
Digoxin.
Then, hey, you know too much. You know too much. It's not fair now. At least guess I'm wrong. So exactly, we are talking about what? Digoxin. Digoxin. So even if you don't know what drug is accumulating there, just know that the drug of choice for chronic cardiac failure is what? Digoxin, which is a long-acting cardiac glycoside. Long-acting cardiac glycoside. And that's what we use. And usually the digoxin are made up of herbs or plants. And these things could be accumulating inside the person, and that can lead to such condition. And what type of accumulation is it? Is it functional accumulation or material accumulation? You can tell me. Functional or material? We talked about it, guys. It's what? Oh, it's what? You have forgotten. This is material accumulation. Material accumulation. Material. We've talked about this. So please watch the videos. I don't give you guys everything here because I want you guys to watch the videos. Okay? So please watch the video so that it can stick better. All right. So here your answer is what? Is D. I explained the difference between functional accumulation and material accumulation. I explained them. So a doctor was addressed by a 30-year-old man. There is a probability of patient being HIV was positive. Now, to clarify the diagnosis, the doctor proposed a polymerase chain reaction. The basic process in this kind of investigation is what? So why do we do PCR? I believe you guys know PCR because if you want to do HIV and things like that, you do what? A PCR, polymerase chain reaction, PCR. And why we do PCR is because we want to make multiple copies of a specific DNA segment. Multiple copies of a specific DNA segment. And using PCR, we are able to achieve that. And this method of making multiple copies of a specific DNA segment is known as gene amplification. Gene amplification. And that is why over here we do PCR because of what? Gene amplification, or the process involved, or the mechanism why we do PCR is for us to achieve multiple copies, known as gene amplification. So your answer here is D. Due to the use of a poor quality measles vaccine for preventive vaccination, a 1-year-old child developed autoimmune renal injury. The urine was found to contain macro proteins. What process of urine formation was disturbed? So anytime you are having a kidney failure, what do you think is going to be affected the most? Who can tell me? Is it reabsorption? Filtration. Oh God. Are you guys sure you're going to be doing the same exams with your peers? If so, then it's not fair at all. So give them the opportunity to also come and learn these things, because you guys know too much and it's not good. It's not good. But I love it, but it's not good. You know too much. So this is what? Filtration. So glomerular filtration will be affected the most. And that is why we normally have increased concentration of creatinine and all those stuff in the blood, because filtration is impaired. Filtration is impaired. All right. So your answer here is what? It's filtration. Filtration. All right. So your answer is what? Is D. It's D. It's D. It's D. And again, you can even see big proteins. All right. 26-year-old female patient with bronchitis has been administered with a broad spectrum antibiotic as a casual treatment drug. Specify this drug. Specify this drug. So a female with bronchitis, okay, with an antibiotic, broad spectrum. So what are you looking at for? Definitely. Now, look at it. So the question now is, looking at your option, let me ask, is dexamethasone an antibiotic? What drug is dexamethasone? Who can tell me? Dexamethasone is a corticosteroid. What about interferon? Usually used in what? For viral infections. BCG, this is a vaccine. Ambroxol, nope. Doxycycline is the only antibiotic in this question. So assuming you don't even know your answer, by method of elimination, you should get your answer right. And this is what doxycycline, which is a tetracycline, also an antibiotic. All other options are not antibiotic. You see how easy the answer is. A 65-year-old man suddenly lost vision in one eye due to retinal detachment. The patient underwent enucleation. Histological examination of the removed eye retina and the choroid revealed clusters of atypical cells. When we say atypical cells, what comes to mind? Who can tell me?
Tumor.
Malignant tumor.
Oh, God. You people are good. With cells of morphism of cells and nuclei with moderate number of mitosis, including pathological ones. And you know when we have mitosis, a lot of, it simply means we have what? Proliferation, uncontrolled production of something. So what comes to your mind is tumor, cancer. So like I said, by virtue of atypical cells, you already know your answer. And that is how to answer a question. Now they say the cell cytoplasm and the intercellular medium contain brown pigment. Again, what controls pigmentation? Who can tell me? What controls
Melanin.
Guys, I'll not even waste my time. What is your answer? Melanoma. This I'll not waste my time. Melanoma. Let's go. Determine the blood group according to the ABO system with salt solution of monoclonal antibodies agglutination did not occur with any of the solution. What blood group is it? Guys, look at it all. They said they are doing a test and they are saying antibodies agglutinations did not occur in any of the solutions. Now, when we say antibodies agglutination, that means the person's antibodies reacting to the blood that is given. And they are saying that there's no agglutination. That means there's no reaction. That means that the drug was, given successfully without any agglutination. So what drug comes to your mind?
Oh.
Blood group O, universal donor. It can give to anybody without any reaction. Of course, outside of rhesus factor. But this is not talking about rhesus factor. This is talking about just the blood group. Blood group O is a universal donor. Now, assuming there was agglutination, what will you think of? Oh, who's telling me? Assuming there was agglutination in all the blood, what would you have thought of?
AB, AB.
AB.
B.
Thank you. The person who like asking me a question, I'm coming to find you. Somebody answering question will be asking me a question. AB. AB is a question. You're asking me a question. That means you're not sure. Please be sure of your answers. Thank you. Be sure of your answers. Otherwise, I will find you. So your answer is what? Is E in this case. All right. One of the factors that causes obesity is inhibition of fatty acid oxidation. Again, one of the factors that causes obesity is inhibition of fatty acid oxidation. Now, I don't know if it is here, but I describe about fatty acid oxidation with you. I'm not sure if it is here. But basically, in fatty acid oxidation, you are burning the fat. The fat is producing or giving you what? Energy. And usually when you do exercises, you do activities, it is burning the fat. It is burning the fat. And let me just rewind again. So anytime you are doing all these things, what hormone will be active? Who can tell me? I love these things. What hormone will be active? When you are fat or when you want to break down fat, what hormone will be activated to activate cyclic AMP?
Adrenaline.
Come again? Oh.
Adrenaline.
No.
Carnitine.
It's what? No, we'll come to carnitine. But usually, the enzyme that is activated is the phospholipase A. You guys have forgotten. You've forgotten when we talk about the phospholipase that is going to activate the cyclic AMP that's going to undergo phosphorylation of substances that will cause activation of so many things. We talk about it. You guys have forgotten. We talk about it. But please watch the videos. Medicine is good. Watch the videos. And the one thing about medicine is that if you don't continue to practice it, you forget it. So please, let's continue to read and watch the videos. I know I talk too much, but take it from me. That's how I am. Either you like me or you dislike me. But I'll advise you like me. If you like me, I like you. Otherwise, I will divorce you if you're a lady. If you're a guy, if you dislike me, I don't even care. All right. So, good. So over here, there's inhibition of fatty acid oxidation. And anytime there's an inhibition of fatty acid oxidation, what it means is that you are not able to carry the fat into the mitochondria for it to be broken down and used as energy production. Of course, you know the powerhouse of the cell is what? It's the mitochondria. So eventually all these things will be transported into the energy place for it to be broken down for energy production. And usually the substance that is responsible for carrying fatty acid from the cell into the mitochondrion for metabolism is called the carnitine. It's called the carnitine. So the carnitine plays a very critical role in energy production by transporting the fatty acids into the mitochondria where they will be burned to produce the energy through a process called fatty acid oxidation. So this is not glycolysis. So don't confuse glycolysis with fatty acid oxidation. In glycolysis, you are dealing with what substance? Who can tell me? Oh. In glycolysis, what are you dealing with? What food substance are you dealing with? Are you dealing with fat?
Carbs.
You are dealing with what? You are dealing with glucose. Guys, don't forget, you're dealing with glucose. So when you break down glucose to produce energy, you call it what? Glycolysis. Glycolysis. And in the absence of oxygen, we call it anaerobic. In the presence of oxygen, we call it what? Aerobic. Please, don't forget these things. Okay. All right. So your answer here is what? Your answer is C. Is C. So that means this is low. That is why they're not able to transport the fatty acid into the mitochondrion for breakdown. During ventricular systole, the cardiac muscle does not respond to additional stimulation because it's in the phase of. I don't know if you guys, of course, everybody will have done this in third year and what you call I think it's under physiology. Under physiology, I hope you guys have done the phases of action potential. You guys have done action potential, if I'm correct. Action potential, where we have the threshold, then we have the polarization or the depolarization. Then you come here, then you go up, then you do this, then things like this. You guys, this is not ECG. This is action potential. Okay, this is action potential. Some of you know all of this, some of these things. If not, please try and review your action potential notes. But in the period whereby a cell is not able to get excited, even after stimulation, we call it absolute refractory phase. Absolute refractory phase. Absolute refractory what? Phase. And this is the period of time between which a second action potential cannot be initiated, no matter how large the applied stimulus is. No matter how large the applied stimulus is. Okay. So at this point, whatever you do, it will not happen. And that's what they say, that no additional stimuli could stimulate this cell. No additional stimuli could stimulate this cell. So here you are thinking of what? An absolute refractory period. An absolute refractory period. So your answer here is what? Is C. Is C. Is C. All right. A patient is diagnosed with acute morphine intoxication. Prescribed the oxidizing agent for gastric lavage. Gastric lavage. And usually you are looking at for what? For potassium permanganate. Potassium permanganate. Potassium permanganate. Usually it has this oxidizing agent. Oxidizing agent. Oxidizing agent. But what is the antidote for morphine intoxication? You can tell me.
Naloxone.
You guys are good. Naloxone, as simple as ABCD. But here they say, what oxidizing agent are you going to prescribe? It's different from what is the antidote for morphine. So always read your question. All right. So answer is B. During cell division, DNA replication occurs after a signal is received from the cytoplasm. Then a certain portion of the DNA helix unwinds and splits into two individuals. It unwinds and splits into two individuals. What enzyme facilitates this process? If some of you are on my YouTube channel, I put a question on, I started doing a video on biology, and I think I did some video on all these DNA polymerases, the ligase, the helicases, the whatever you're looking at over here. So I will entreat you to go and watch it. But I think I'll also try and then send you guys the link to go and watch a full video on what I did on that topic. That time I was starting, that was like 4 years ago when I started realizing my talent of teaching anyways. So I made a lot of video. I did a video on it. So I'll recommend you guys will watch it. So I'll send it to you guys later on after this presentation. But basically, you are dealing with what? With helicase. You are dealing with what? Helicase. And helicase unwinds the DNA template at the replication fork. Replication fork. Fork. Don't go and say your teacher is profane. Fork, unless you have a way of pronouncing it, but it's fork. Okay. All right. So helicase, the function of helicase is to unwind the DNA template for replication so that cells can duplicate. Cells can what? Duplicate. And we have what we call the DNA dependent RNA polymerase called the primase. We have the ligase, we have the polymerase, and I think one of our tutorial, we talk about the different types of polymerases. The polymerase 1, polymerase 2, polymerase 3, we talk about them all. So please do well to watch the videos. But after this presentation, I'll surely send you a video on topic on replication. So answer here is D. All right.